Welcome to the Jerry Pal Podcast. This is Eric Widera.
This is Alex Smith.
And today we have a special guest with us today, Dani Chammas, who is a psychiatrist and a palliative care doctor, and just gave a wonderful talk to our fellows on an interesting topic, which we will get to. But maybe before that, Dani, we usually ask our guests to give Alex a song that he should sing.
I'm going to go with Free Fallin' by Tom Petty.
Free Fallin'. Great song. She's a good girl. She loves her mama, loves Jesus, and America too. She's a good girl, crazy about Elvis, loves horses, and her boyfriend too. It's a long day living in Reseda. There's a freeway running through the yard, and I'm a bad boy 'cause I don't even miss her. I'm a bad boy, I'm breaking her heart. Said I'm free, yeah, I'm free falling, yeah, I'm free, yeah, free falling.
Dani and I both have our lighters going right now up in the sky.
That's right.
It's a good song choice.
So we just had a really interesting morning core curriculum talk on formulation. Alex, have you ever heard of formulation before?
I don't know, drug formulation?
Apparently not drug formulation, because that's what I was thinking initially. Dani, what is a formulation, and why should we use it in palliative care and geriatrics?
So a psychological formulation in the therapy world is what you think is the core underlying issue in someone's psyche that's getting in their way or tripping them up, right? So similar to, heart failure or in internal medicine, if someone comes in with chest pain, you don't think about treating the chest pain. You think, what is causing this? What's underneath? And that guides your treatment. In the therapy world, it's the same with communication. You don't just look at what the patient's saying or doing. You think, what is the formulation? What is the root behind this that's causing this? And that guides how you treat it.
So what's the formulation for Trump?
How long do we have today, Alex?
There could be a lot of different reasons people say things that they do. How do you know what's the underlying reason that they're saying something that, like, why did Alex just bring up Trump?
Yeah. So it's a good question. And in general, you don't pick one specific thing a person did, but sort of a guiding formulation. But I will say it takes 4 years of psych residency to even start feeling comfortable doing formulations. And then people keep doing this in therapy and practice for years over their career. This is why therapists tend to only get better with time. So it's a hard thing to do. And I guess I'm not advocating that everybody in palliative care immediately know how to formulate, but I am advocating that they slow it down to take the step to wonder what is the root behind the behavior.
And what's an example?
Let's say the behavior you're seeing is that you're in a family meeting and the family is stuck, right? They do not want to make a decision. You're trying to get at goals of care and they just can't.
Okay.
Right? There could be different reasons, right? There's not one thing you do for a stuck family meeting. If my psychological formulation is, oh my gosh, this family is so overwhelmed by the responsibility of this choice. They are petrified of doing the wrong thing, that they're going to have to live with that burden forever. Then my communication tool is going to be something that takes away that responsibility from them. I might give them my strong recommendation. I might stop presenting it as a choice and just say, this is what we should do. But if my formulation is that their psyche is really stuck on a feeling like they think that their loved one is just, another person to the doctors, that the doctors are pushing their agenda and that they don't see them as an individual and that they're trying to force me one way or the other. Things are going to go south if I start giving them strong recommendations, right? So based on my formulation that the real core issue is, am I seeing their father as a person? That's the place where I might start saying, tell me about your dad. Tell me what he would want if he was here, right? I'm going to pick different tools from my toolkit, just
Right.
like you'd pick a different nausea med for if you had a different cause of nausea, or a different chest pain med if you had a different cause for chest pain, right?
So it's like if I could, this is completely new to me, so I'm just going to make up some words, and you can tell me if this is a close approximation of what you're talking about. It's like trying to understand the underlying reasons that may be unspoken behind a person's motivation for the way they act, behave, or say.
Exactly. And what we find in the therapy world is that actually, you can see a huge array of symptoms, but most people have a few core underlying beliefs that are guiding most of the things that come up in their life, right? Is it that I'm unlovable? Is it that I'm, to blame for anything that goes wrong? Is it the world's to blame? Who knows what it is? But most people have some organizing compass that might be leading them astray, and you pick your therapeutic communication intervention to address that. Otherwise, you're just shooting at the dark, throwing different tools and communication styles at people.
So how do you figure out what those underlying issues are?
So what I would hope for the field of palliative medicine, I think that people come into palliative medicine because they're inherently good communicators, right? And I think there's a good amount of intuition already in this field, and you see it happening, right? You see someone become naturally more paternalistic. Something's going wrong and they just do it. Or you see them become a little bit more soft or a little bit more this or that. What I think we need in this field is for this process to become explicit. The same way everything else in medicine is explicit. Why? Why did I become more like this? Why did I become more like that? What am I going to try with this family? What do I think is going to trip up this family?
Yeah.
Right? We debrief our family meetings. We say, okay, team, what worked and what didn't work? Well, what does that tell us? That tells us what worked or didn't work for them. But can we extrapolate that to every family? No. So what worked and what didn't work? Why? Why in this case? And I think the more we're doing that out loud, the more we're going to learn and be able to hone something that we're all relatively good at baseline.
It seems like you'd have to know the individual participants in the family meeting fairly well in order to extract, in order to deduce that underlying motivation. But are you saying that even without, knowing the individual participants in the family meeting, as well as you might know them as, say, if you had individual therapy sessions with each of them, you can still draw some ideas or conclusions or suppositions about what might be going on that would help your approach?
Yeah. And I have a few thoughts on that. It's there are different levels of formulating, right? Am I going to formulate, the core issue that this family has struggled with for years? Maybe not, right? I don't know their childhood histories and whatnot.
Right.
But can I formulate what is tripping them up around the end of life care for their dad, or what is psychologically the barrier in whatever medical thing is going on? Yeah, I think we can do that pretty quick. And I think we all are doing it. We're just not doing it explicitly. I'll add, if you watch a master therapist out in the community, Alex, and show them about a 4-minute clip of one of my own therapy sessions, we used to do this in psych residency, you'd show them a 4-minute clip and they'd stop and be like, wait. Let me tell you what's happening for this patient. And it was amazing what they could figure out from 4 minutes.
Wow.
So, yeah.
So maybe it would be helpful just to do maybe a little practice session. You give us a case, Alex and I will try formulating. Maybe that can help me put my head around this topic.
All right, okay, here's a case. You tell me what you think of this one. So let's say you're in a family meeting, right? And a decision needs to be made right now about the course of a patient's care.
Okay.
Right? The families are listening to what the doctors have to say, but they just refuse to make a decision. They keep saying, okay, thank you for this information. We need more time. We want more time. Meeting after meeting, we want more time. You can't get a decision. Let me be clear. There isn't a right answer to this. This is a sample case. I don't know the formulation. What might be a formulation for what's leading to this issue?
It could be that there's a fear of making the wrong decision. And that strong fear leads to no decision.
It could be that they're waiting on a family member to come in from another town.
Okay. So they might be petrified of making the wrong decision. They might feel like that's, if you went farther into the family member thing, what is...
Because they don't want to make it alone, this decision, or there's an important family member who makes most of the decisions, or there's a lot of different dynamics in the family where there's a lot of arguing over past wrong decisions.
So maybe they're scared of being blamed. Yeah, that could be something.
It could be that they are the type of family that looks to the doctors to make a decision, and that they just aren't in the habit of making decisions. And that maybe it's, so what would you do, doc?
Mm-hmm.
Or you need to make a suggestion as a doctor. Would a recommendation help in this sort of case?
So now you're getting into what your communication tool would be based on your formulation. But
Right.
yes.
Right.
Could be those things. What else could it be?
Could be the family is scared because their loved one is dying, and if they don't make a decision, it may make them feel like they're not dying, or they don't have to deal with that issue.
Mm-hmm. It could be avoidance of acknowledging a really huge truth they don't want to acknowledge. So let me pause you, Eric. So let me pause you there. Yeah, what do we do? You took it right out of my head. So let's take that one. Let's say that you think the reason they're not making a decision is because that means they have to truly acknowledge that this person is dying, and they are petrified to do that.
Mm-hmm.
What might you say to that family?
Maybe go back into my toolbox, acknowledge the emotion that this is really hard to be in this situation, to have their loved one this sick in the ICU.
Yeah.
Yeah. Draw out from them what they're feeling at this time.
Mm-hmm.
What is your what are you seeing? What are you worried about? And maybe getting the other members of the team to use the word dying if they're using it amongst themselves. A lot of times, the docs will say, I think they're dying, but then they won't say that to the family.
Yeah. So you guys right now, as you're picking your tools, you have a compass, right? You're thinking to myself, I have a guess at what the psychological holdup is. And in my mind, I'm thinking, I want this family to feel the message, oh, what's hard here is not the decision. What's hard here is that this person is dying, and that we all sit here and own the fact that this person is dying.
Mm-hmm.
And we're not going to move forward till we do that.
Yeah.
Right? But if I had backtracked, guys, and I had picked one of those other formulations that you had brought up, this strategy might not make sense.
Mm-hmm.
Can you give me an example?
Let's say this family's issue is that they are distrusting of healthcare, and they really don't think that you care about their father. They think you want to get him out. They think you're just trying to push an agenda, have it be done. You keep coming in for this decision, and they're like, whoa, 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 hold up. This is our father. Stop pushing. We're not ready. If you go in there doing things that just want to underscore that you really think this guy is dying, let me make sure in my communication that this family gets that my thought is this guy is dying.
Right.
Let's sit with him dying.
I've never been in a situation like that where...
Completely foreign.
Right,
Where do you
that
come up
is
with these
not going to
things?
go well. Right, and but we see this happen, right? We go as palliative care to these meetings, and we see like sort of the train. You see the crash coming, and you're like, no, don't say it, like, and then we adjust, and we're doing so much of this implicitly. We're like, let me jump in and ask you about blah blah blah. Like, let me jump in here, but there's so much less potential to grow, and there's so much less potential to teach if we don't then later think back and say, why? Why did I do this? Why did this work or not work?
It also sounds like your initial formulation may be wrong, and you'll know it's wrong, and then you may have to pick a completely different formulation. So, for example, if I thought, oh, they're just not acknowledging death, and they respond as they would if they were just mistrustful of the healthcare system, I would have to change my formulation pretty fast.
Yes. And you'll know it doesn't work, right? If I'm thinking, oh, they're not acknowledging death, and I sit, I take a deep breath, and I say, they're dying. And they look back at me and they're like, yep, they're dying. And then there's like a pause, right? That might be a clue, like, okay, that didn't work. My communication wasn't therapeutic. The same way that I give, Dilaudid, and the patient says, nope, my leg still hurts. I'm like, oh, okay, that didn't work. What did I have wrong here? And you adjust. But what we don't want is people either A, seeing something working and thinking, okay, that's going to work. That's how I do it. That's how I do family meetings. That's how I break bad news. That's how I do it. Because it's going to be different for everybody. And we also don't want people just like shooting in the dark. Oh, this didn't work. Let me ask hopes and fears. Oh, that didn't work. Let me ask this. Because there's so much less potential for growth if we're just kind of keep shooting in the dark from some pretty good tools. We have a good toolkit.
Right. So are there things that I can do as a palliative care provider to practice this skill or learn more about it?
Yeah. So let's start with practice. And I started to say this, but I think some things. Number one, like I was saying, make your thought process explicit. Don't just recommend something communication-wise to another team, but tell them why. Or when you're going into a meeting with a team and you've done some debrief and given them your tips, maybe ask them something like, you know this family best. What do you think is going to trip them up? What's going to be their core struggle in this room? Right. By asking these questions, not only are we setting ourselves up for a much better family meeting than our basic, pre-hash does, but we're teaching them to think like this. We're teaching ourselves to think like this. So it'd start there. And then I would add communication. Some people get really bothered by the thought of changing their communication. Like I'm telling them to be a robot. Like for this type of person, say this. And for that type of person, say that. And that's not what we're advocating at all. What I would add is knowing yourself really well helps, right? Know the types of formulations, the types of family meetings, the types of holdups that your natural style and the tools that you like to go for naturally work well with. Go in on autopilot with those ones. And then know the ones you get tripped up on so that you can think through, okay, I think it's this formulation. Before I go in, let me think about how I might tweak my natural style. Do I need to be a little bit more paternalistic, a little less, a little more straight shooter, a little less, softer, harder, and find authentic ways to tweak yourself. Not change yourself, but tweak yourself so that you're therapeutic to the person.
That's great. I wish we could also, like you said before, when you were in training, you had some master, therapist look at your therapy sessions for 4 minutes and give you feedback. That was remarkably elucidating. I wish we had some sort of coach that could come with us. I think back to my training, like having Susan Block there. Learned so much from having those encounters. I wish we could videotape our family meetings and bring them to Dani so that she could tell us what was going on.
That'd be really fun and a great way to think through it. Yeah, I mean, majority of my psychiatry therapy learning happened sitting in a room watching someone way smarter than me watch clips of me fumble.
And maybe for suggested reading so we can learn a little bit more about this, we can put some articles up on our GeriPal website with this podcast.
Yeah, we'll look for some. I was, it's funny in therapy, I don't know how much you guys experience this, but people are very, very wedded to their school of therapy. Like, I'm an analyst, I'm a CBT person, I'm a family therapy person. And so they all teach formulation, but they do it with their own little words and their own little processes. But the content of it is so similar. So maybe we can get a few examples from different schools and whatever speaks to you. It's different ways up the same mountain.
Okay, you have one more comment?
I have one more comment, yeah. I was just thinking about how sometimes when you're sitting in a therapy case, you can go hour after hour with somebody, and then you hit something good because one thing you say lands differently, and the whole energy of the room changes. And I know you guys have been in a lot of family meetings.
Yeah.
You've had that feeling, right, where the meeting's going one way or another, and one comment from one person just shifts the energy, and you know it. You're like, oh, we hit it.
Right. And I think
now we know where we're going.
And in our debrief about it, we too often go to what was the information content there rather than what's the underlying psychological construct, that dynamic that was going on in the family meeting. What was the formulation behind that change, not just the information.
Exactly, because if we went with the information, that would just mean that one comment is going to be your money spot for every single meeting, right? And it just doesn't work like that.
Yeah, this is not although it's called Formulations, it's not a formula.
It's a bumper sticker.
Well, thank you, Dani.
Awesome, guys.
Thank you so much,
you.
Dani. So, sometimes you're in that family meeting and you feel like you're in free fall.
Sometimes you do.
I was wondering how you're going to bring up the song, Alex.
This is my favorite verse. I want to glide down over Mulholland. Want to write her name in the sky. I want to free fall out in the
nothing. I'm gonna leave this world for a while. Said I'm free, free falling. Yeah, I'm free.